Rudy, welcome. Suspicious Bunch, welcome. All right, so let's go ahead and get started. Today we're going to be doing a mini lesson on common conditions of eyes and ears. I am ChicagoDLSinc. I do Naplex tutoring. We have group sessions available in both the morning and the evening, as well as one-on-one tutoring. Feel free to reach out if you've already taken the Naplex and have a score report. Can go over that with you. If you have taken an assessment and are apprehensive before taking it, the actual Naplex can discuss that with you. Have done reviews even with fresh graduates. So we'll go ahead and get started. Once again, the resources that I've used are RxPrep and Pass Naplex Now. Both are phenomenal resources. Uh, the more you use them and do the practice questions, the better your result will be. Common question is asked. Um, is one better than the other? I think both. That's all up to individual preference. Uh, and then save your questions for the end of the presentation. I'm happy to answer any and all questions. So we'll go ahead and begin. Vicky, welcome. And some new faces, some familiar faces from yesterday's session, and I hope today is just as fruitful for you. So, background. Most conditions of the eye and ear systems are treated topically, and this is helpful in reducing adverse effects systemically. Now, there are conditions that you need to treat with oral medication or, in severe cases, IV medications or IM. Those will not be covered in in this session. ID antibiotics do a good job covering those. So eyes are more sensitive than the ears. What that means is you can take your eye drops and use them in the ears, but you cannot use your eardrops in the eyes. And the reasoning for that is it may not be a sterile preparation, may not be isotonic, or the pH may not be appropriate. When it comes to prescribing or scripts, it's better to write out right ear, right eye, left ear, or both. The Latin form, excuse me, are ADASAU for ear and ODOSOU for eye. And D is going to be right, S is going to be left, and U stands for both. You may also the ODOS may look familiar if you've had an eye exam and noted your optometrist script. For solutions, one drop is equal to 0.05 ml. Suspensions, you shake well. I have had a practice question about suspensions. It is a select all that apply, and that was a question about instructions to the patient. Ointments apply to the conjunctival area or lid margins. This is useful in blepharitis, and we'll talk about that later. Ointments can make your vision blurry and do not use with contacts. For gels with the cap on, you'll invert and then shake it once to get the medication to the tip and then instill into each eye. Something we will talk later, but don't touch the tip of any medication to the eye itself. All right. So, glaucoma. This presentation has a few more pictures than yesterday, and I hope they are helpful. So, what? Glaucoma is damage to the optic nerve. Sorry for the typo, I'll fix that. And loss of visual field due to increased intraocular pressure or IOP. There are two kinds. One is called open angle. Sometimes the patient will present without symptoms, and during their eye exam, the IOP will be raised, and this can be treated with eye drops or elective surgery. Angle closure or closed angle. This is an acute, and it can be an urgent or emergent condition. Uh, and I'm going to offer some nuance here. For the test, it's going to be emergent. It's always an emergency. However, if a patient presents in the morning and there's an ophthalmologist nearby or the hospital has op- ophthalmic coverage as a specialty, it can be done urgently in the same day. But it does need to be attended to right away. The picture is an example of angle closure or closed angle glaucoma. You will see redness, there will be eye pain, headache, and vision changes, and this is due to a sharp, sudden increase of IOP due to blockage. Now, what do I mean by blockage? Aqueous humor is the fluid in our eye, and it's produced and drained, um, similar to fluids in a vehicle, and it lubricates the eye and has functions. And so too much of it is not good, too little of it is not good, too little of it ends up with dry eye, which is something we'll talk about later. So uh, on the left side here, you'll see healthy eyes. I'm not sure if you can see the cursor of my mouse, but healthy eyes. And then with glaucoma, as you can see, you lose the periphery and similar to tunnel vision. All right, the next slide says glaucoma meds, and the treatment goals are to reduce aqueous humor production. This is through beta blockers or carbonic anhydrase inhibitors. Examples of beta blockers are timolol and betaxolol, and then carbonic anhydrase inhibitors, dorzolamide and brinzolamide. There are others listed in both resources. I choose the bold ones. And we can also increase outflow or drainage of the aqueous humor, and that's going to be through prostaglandin analogs like latanoprost or travoprost. Alpha 2 agonists can do both, and brimonidine is the most common brand. Another brand, cholinergics, these can increase outflow, carbachol and pilocarpine. These are used less and less unless there are caution or contraindications for the other classes like beta blockers and carbonic anhydrase inhibitors. Next, we have conjunctivitis. Sorry. Can everyone see that slide? Just want to confirm you can see conjunctivitis. Very good, thank you. So this is also known as pink eye, and it can be unilateral or bilateral. Just to clarify, unilateral is in one eye, bilateral is in both eyes. And the conjunctiva is the protective membrane and it lines the eyelid and protects the sclera, which is the white part. So if you look at the picture and you see the redness, that area is usually white and that is conjunctivitis. Symptoms, you'll see swelling, itching, burning, discharge, and redness. Discharge can be clear, it can be yellow, it may be green, it may be a little bit, it may be a lot. And you can have all of these symptoms or any combination of. It can be caused by a virus, bacteria, or allergens. And we see it mostly in young children. and it is highly contagious. A lot of adults that will present with conjunctivitis will say their child has a daycare school, something similar in their history. There are certain instructions we give with conjunctivitis. Avoid touching the eyes, proper hand hygiene, and just to clarify that, that means frequent and proper hand washing. Discard eyeliner, mascara, or other mascara, sorry, or other uh, makeup that you use around the eye, and change towels and washcloths daily without sharing. Viral causes, the most common is adenovirus. There's no treatment specifically. You can do symptomatic treatment if there's pain um, with over the counters. It is usually self-limiting and the course can run from days to weeks. Next, we have bacterial causes. Um, this is out of order, but we'll do the types first: Staph aureus, strep pneumoniae, Haemophilus influenzae, and Moraxella. These four are the most common causes of bacterial conjunctivitis. Some of the treatment options we have, these are also listed backwards. Neomycin, polymyxin B, dexamethasone, or trimethoprim, polymyxin B. The fluoroquinolones, moxifloxacin or ofloxacin, these have wider coverage, and as we empirically or without cultures and sensitivity will treat conjunctivitis, defaulting to a broad spectrum is sometimes easier. Last but not least, we have allergic causes: pollen, dust, dander, or mold. And then, of course, not limited to, you may come in contact with something with your hands, touch your eye, and it may cause an allergic reaction. We can use mast cell stabilizers. Cromolyn is well known. Antihistamines, azolastine or olaptidine. Olaptidine, brand name is Pataday. I believe Pataday is now both over the counter and prescription. And then combo of a mast cell stabilizer and antihistamines. Two brand names are Alaway and Zaditor. All right, moving on to blepharitis. Blepharitis is eyelid inflammation, and I just want to draw your attention to the picture. I know the eye is red, but if you look at the actual eyelid, on the bottom lid, you can see some of the eyelashes are missing. And on the top, you can see the redness is not just on the margin, but it's starting to go backwards or higher up. And this is where the eyelashes come from. It can be both acute and chronic. The primary symptoms are inflammation, irritation, and itchiness. And treatment options are warm compresses over the eye, warm, moist washcloth with baby soap or baby shampoo to wipe. And you can also use, if necessary, antibiotic ointments. Be careful not to get them into the eye, steroid eye drops, and artificial tears if dryness occurs. Now, I myself have been a patient of blepharitis, and it is quite an irritating condition because you're not supposed to itch because that leads to, or rub your eyes because that leads to inflammation, which makes the situation worse. But all you want to do is rub your eyes. And so I asked, why do we use warm compresses instead of cold compresses? Uh, as you may know, we use cold when something is inflamed or there's redness, and the warm compresses are actually to improve circulation and to remove any waste or help with the improved circulation, you're improving the immune response. And so it's supposed to help in the long term, but it may exacerbate in the short term. We use baby soap or baby shampoo because it's usually plain. There's no added perfumes or chemicals, and which can cause further irritation. And um, Some places, a pro tip, if you don't have children, you can find a travel size of baby shampoo and just use the rest when you're done treating your eye. Um, it's quite excellent. Let us continue. Now, symptom-based treatment. If there's inflammation, we have several options. We can use steroids. Prednisolone and dexamethasone are two of the most used if you have inflammation in your eyes. NSAIDs, ketorolac is the most common, both for the Naplex test and clinically. And then zero ophthalmia is dry eye. And you can use Refresh or Systane. Both of these are over the counter. For chronic dry eye disease, you can use cyclosporin. The brand name is Restasis. For redness, you can use nafazoline or tetrahydrozoline, and these are known as Clear Eyes and Visine, which are also over the counter. You may have seen a commercial or an ad where it says Clear Eyes, and that helps remember. And just know with the over the counter, you you should also counsel the patient like, hey, if it doesn't get better in a certain number of days, make sure you go back and look that up, whether it's 3 days or 5 days, to definitely go get that checked out. All right, very good. Now, medications causing ophthalmic issues. These are specific. There is a chart in RxPrep and with the medications in Past Naplex Now. So, excuse me, retinal changes or retinopathy we see with chloroquine or hydroxychloroquine. Amiodarone, ethambutol, and linezolid can cause optic neuropathy. For ethambutol, it starts with an E. E for eye is helpful, especially if you're doing TB and the adverse effects. Next, we have floppy iris syndrome. This is an adverse effect of alpha blockers like tamsulosin. And you may think tamsulosin is not used topically. However, there are alpha receptors in the eye, and therefore this can be an adverse effect. Next, we have color discrimination. You see this with dig or digoxin. With toxicity, you'll see greener. The patient will complain of green or yellow vision. With PDE5 inhibitors, greenish tinge, and the antifungal voriconazole, you can have color vision changes. Next, we have medications that can cause vision loss or abnormal vision. Once again, digoxin toxicity, patient will complain of blurriness or halos. PDE5 inhibitors can cause vision loss, unilateral or bilateral, and this can be permanent. Isotretinoin, decreased night vision, dryness of the eye, and irritation. Topiramate can cause visual field defects. Vigabatrin can cause permanent vision loss, and voriconazole can cause abnormal vision and photophobia. All of these that are listed here are in the study guide as well as past Naplex. All right. Next, we will move on to common ear conditions. And before we continue with common ear, please know that this is a mini lesson. This is not a comprehensive review. There may be some things that you were tested on that I have left off. And during your prep, please make sure that you cover that. Crimson, welcome. So, common ear conditions, we have cerumen impaction, also known as too much earwax. Symptoms can be earache, hearing loss, and this can be removed manually using probes or via irrigation in the medical office. I have had this procedure of irrigation in the medical office as a child, and I do not have fond memories. but I do remember feeling much better afterwards. So, the medications that we can use, cerominolytics, once again, we are not being tested on pronunciation, forgive me, soften earwax and can dissolve it as well. Debrox is over the counter. It is the most common, and it is carbamide peroxide. The instructions are 1 ear at a time because if you put it in one ear and then immediately put it in the other, it will just run out of the other ear. It will not have time to act. And we limit the use to 3 to 5 days. Patient may wake up and see dissolved earwax on their pillow, and um, and so that's that. Also, water, saline, mineral oil, hydrogen peroxide can be used. They're mentioned. I am not uh, a fan of those methods. However, if it's in a test question, recall. For the most part, it's either manually or via irrigation. Otherwise, Debrox is great. Next, we have otitis externa, OE. This is also known as swimmer's ear because a lot of patients will report water exposure. And it's the biggest risk factor. Uh, Allowing the ear to dry or ears is helpful prevention, as well as if you're a swimmer or doing water sports regularly, using earplugs. For mild cases, Vosol HC, which is acetic acid, and hydrocortisone is an option. For pain, you can use NSAIDs or acetaminophen. And for moderate or severe cases, you can use combo otic drops. Most common are Ciprodex, Tobradex, Cipro 8C, and Cortisporin TC. Now, Cortisporin TC has a steroid along with, I believe, neomycin and polymyxin. The Cipros have ciprofloxacin. Dex is dexamethasone. Tobradex is going to be tobramycin and dexamethasone. Cipro 8C is going to be hydrocortisone. Next, we have tinnitus or tinnitus. You'll have ringing, roaring, or buzzing sounds. They can be episodic, meaning they can come and go, or they can be constant. For patients that suffer from this, it can severely reduce their quality of life. It can be caused by noise exposure or trauma, noise trauma, and like loud explosions. And so, if you're going to concerts, listening to loud music, please be mindful. Idiopathic and drug toxicity. So, drug toxicity is a testable concept, especially the adverse effects. The four most common that I found were salicylates, NSAIDs, methotrexate, and erythromycin. One that is not on here is let's go back up to otitis externa. If the if the patient has a ruptured tympanic membrane, just a little baseline anatomy. That's the covering between the outer ear and separates the middle ear. That leads to the inner ear. If it's ruptured or has a hole, you cannot use any aminoglycoside because, as we know, aminoglycosides are toxic or ototoxic. And so um, that's not on here as drug toxicity. The systemic ones are. But just remember that aminoglycosides or aminoglycosides, potato, are ototoxic. All right. Otitis media, it's covered more in ID and antibiotics. We treat with oral antibiotics. Um, so let us continue. Next, we have key counseling points. If I can just get a yes that you can see this. Right, very good. Thank you. Tony, welcome. I'm not sure if I welcomed you. So, key counseling points. All eye drops can cause stinging or burning. There are less reports if the eye drops are preservative free. Now, you may say, well, if there's no preservatives, everyone is different, everyone feels differently. If a patient says it's stinging or burning, go ahead and believe them. We wait 5 minutes in between two drops of the same medication. If they're different medications, we try to wait 5 to 10 minutes. If you're going to use a gel alongside the drops, do the drops first and then wait 10 minutes to put in the gel. Remove any contact lenses and wait at least 15 minutes before reinserting. Now, does anyone here know what the washout effect is? And if you do, type it into the chat. This is key when doing drops. Okay, we have a no, which is okay. All right. So the washout effect is if you put in 1 drop of medication or if you're putting in the drops and you don't wait long enough for those drops to be absorbed and you put in another medication, it will literally wash out the first one. And that's why the patient is counseled that you need to wait 5 minutes if it's the same medication and 5 to 10 minutes if it's two different medications. This was actually a practice problem on an assessment. I don't recall if it was the pre-NABP or RX Prep or past Naplex now, but it was something I went over with a student, former student. Next, we have prostaglandin analogs. Darkening of the iris and an increase in eyelash growth can occur. Do not use with Latisse, which is bimatoprost. It can reduce effectiveness. Another key counseling point, and these are general, 20 drops per milliliter. Always check the label. Wash hands and shake the bottle if it's a suspension. The tip of the bottle should not touch the eyelid. All right. So now what we'll do is we'll start with the first question. And uh, for those that were here yesterday, we'll do the same thing. Mr. Turtle, welcome. What we'll do is, and just to refresh for the new attendees, I'll read the question, give you time to think about it. At the bottom, I've written what area of competency the question is touching, and at the end, when I'm done reading, please put your answer choice in the chat. That'll give everyone a chance to attempt it. If you don't know, I still ask you to guess. You can put a question mark by it if you would like, and then we will go over this question together. So, Susie is an 8-year-old female who comes into the clinic with complaints of ear pain and discharge. Oh, apologies. Sorry, ear pain and fever over the past 3 days. Otoscopic exam reveals a red bulging tympanic membrane and her temperature is 102.5. The physician assistant wants to start Susie on antibiotics for acute otitis media. Excuse me, but her mother reports an anaphylactic reaction to a penicillin agent 2 years ago. Can't remember the specific agent and recently moved here. What is the most appropriate recommendation? And so this is area 3, which is develop or manage treatment plans, and area 1, obtain, interpret, or assess data, medical pertinent information. Whenever you're ready, go ahead and start answering. Thank you for those of you that are indicating you're guessing or you're unsure. Please make a note for you when you go back and review. And while we give everyone a chance to respond, just remember that doing the questions is part of your journey. You do need to go back and review your incorrects, understand why, and then maybe do more practice on the topic that you got wrong. Your prep is the time to make mistakes. So when you take the Naplex and also the MPJE or CPJE, if you're going to, that you do your best and have a good attempt. Okay. 1, 2, 3, 4, 5, 6, 7. Okay. All right. Loveful, welcome. What we'll do is let's go ahead and go over this. The correct answer here is C, and um, you may challenge. Let's talk about why. You're supposed to challenge penicillin allergies. However, anaphylaxis is not something that you challenge. Mild, you can. If they say they had a headache or a rash or something like that. But of course, this is subjective. Anaphylaxis is not subjective. This is a true allergy. So, so C is the correct answer choice, azithromycin. And the reason C is correct, um, Cipro, we'll start with D. This is a rule out question. Cipro has broad coverage but lacks dependable coverage for strep pneumonia. And that strep pneumonia is the primary bacteria responsible for otitis media. So D would be incorrect. Because this patient has anaphylaxis, which is a true allergy, we can cross out amoxicillin. And choice B is cefadroxil. And cefadroxil belongs to the class of antibiotics called cephalosporins or cephalosporins. And there is a bit of a cross reactivity. I have seen numbers from 1% to 20%. However, cefadroxil specifically shares an R1 side chain with amoxicillin. And because of that, uh, cefadroxil is also ruled out. I will also say in questions like this, it is safe if they have a true anaphylaxis or severe allergy to penicillin, you can rule out most cephalosporins. If you go back and review cephalosporins and you see one that has no chains common with amoxicillin, definitely make a note of that. So some of the challenges that you can do are direct challenge, graded challenge, or penicillin skin testing, because many penicillin allergies have been shown to be false, or they're just adverse effects, normal adverse effects. Uh, Another thing, does anyone know a common brand name for amoxicillin? Type it into the chat. Amoxil is a good one. What about for C, azithromycin? Good. Trimox is another one. And also for D, ciprofloxacin. Good. Cipro. All right. So Art asks, is there a specific detail in the case that shows it's strep pneumo and not other bacterial infections? It does not. If it was a different cause, they would have um, they would have something in the stem about that. Because strep pneumo is the most common cause, that's the assumption you should have with otitis media. Also, Cipro, when you do your antibiotic review, it's not used for upper respiratory infections at all. And that's because of um, there's no dependable coverage for strep. All right, good. Next, Vicky asks, what's the minimum age you're welcome. What is the minimum age for fluoroquinolones? So I'm going to give a bit of a nuanced answer. If it's uh, fluoroquinolones are avoided in peds. Uh, if it's topical, I believe it's 1 year, 1 years old or greater. And for second line or third line, I believe teenagers, we prefer a teenager. However, you do have to evaluate one of the side effects of tendon rupture. So, for example, if it was a 16-year-old high school athlete and you had to choose a second line or third line, I would try to leave fluoroquinolones until the end. Maybe someone can chime in here. If you've taken the Naplex, they don't necessarily trip you up or try to trip you up. It is supposed to be a baseline exam. Life will trip you up on its own. The NABP does not try too hard to do that. All right. Any questions or concerns about this one, this practice, before we go on to the next question? Good job, everyone. Even if you got it wrong, it is okay. All right. Continuing to the next question. So this is an area 1 and 2 question. We're going to be identifying drug characteristics as well as obtaining and interpreting data. So AB is a 74-year-old male who is shopping for groceries when he stops by the pharmacy with a question. If you've been a grad intern, I'm sure these are one of your favorite consults. He has recently been having a change in his taste sensation marked primarily by bitter taste with both food and drink. He currently takes pravastatin 80 milligrams at night, lisinopril 40 milligrams once daily, loratadine or loratadine 10 milligrams once daily, and levothyroxine, excuse me, 112 micrograms once daily. And last but not least, Cosopt, 1 drop in left eye twice daily. Cosopt is going to be timolol or dorzolamide. Which of the following medications most likely could be causing this side effect? Go ahead and take a look. And whenever you're ready, go ahead and put it in. Okay, I've got 6 answers. Anyone else, go ahead, and then we'll discuss this. All right, so the correct answer is E as in excellent. Cosopt is a combo product that we use in the management of glaucoma. It contains timolol, which is a beta blocker, and dorzolamide, which is a carbonic anhydrase inhibitor. And so, topical carbonic anhydrase inhibitors not only cause local or ocular side effects like stinging, burning, or blurred vision, but they can also It can also cause a systemic symptom of altered or bitter taste. And this is an important question where you're supposed to remember that some topical medications can cause systemic side effects. None of the other choices have any adverse effects of taste disturbances. Okay, so um, this was once again area 1 and 2. Did anyone have any questions or concerns about this practice? Well, Vicky asks, to answer this question, we would have to know the side effect profile for all drugs. The most common, yes. So while you're memorizing the top 300 brand names and generics, you do need to know the most common adverse effects. So now you know as a class if there are any carbonic anhydrase inhibitors that are topical, they can cause altered or bittered bitter taste. I'd like to remind you, I mentioned this yesterday. Uh, you don't have to get everything right. You do have to get a lot right. For all 6 areas of competency, you do have to get a 3 or better. So if you are going over the medications, the adverse effect profiles, and you know 2 of them and not the third, I would not fault you, but you do need to try your best for the common medications, especially the ones that are bolded or in study guide um, to do that. In Genesis, you had a question, but it seems like you got it. Loratadine is a receptor, histamine receptor blocker. Just a heads up. But I guess it is an H1 receptor blocker. All right. Any more questions about this one? And then I'll open up the floor for questions, general questions. If you have a general question, if you want to go ahead and start typing or ask. While we wait for questions, once again, I am Chicago DLS Inc., Chicago Diverse Learning Services. I offer one-on-one Naplex tutoring and small groups. I'd like to thank Suspicious Bunch and the PharmaPrep server, as well as Pharma Turtles. They're both doing great work, helping students prep, providing those resources that you need, and uh, great job on that.